In our last class, we talked about rhythm and about how electricity has to work before the pump can. Today, we go one layer deeper to the muscle itself and to what happens when that muscle stops getting the blood it needs. Here is a fact that surprises many students. The heart does not feed itself from the blood inside its chambers. It feeds through the coronary arteries, which branch off the aorta and wrap around the outside of the heart, and they fill during diastole, when the heart is relaxed. That detail matters clinically. If a patient's heart rate becomes very fast, diastole shortens, and the heart has less time to perfuse itself exactly when it is working hardest. A fast heart rate is not just a number on a monitor. It is a threat to the heart's own blood supply. So today's topic boils down to a discussion about the oxygen supply to the myocardium versus oxygen demand. When demand exceeds supply, the muscle becomes ischemic. Ischemic muscle hurts, and it stops contracting well. If the imbalance lasts long enough, muscle dies. That is infarction, and it does not grow back. Let me start with the condition that is not an emergency, because you need it as a contrast. In stable angina, plaque has narrowed a coronary artery slowly over years. At rest, enough blood still gets through. But when the patient climbs stairs or gets upset, demand rises, the narrowed artery cannot keep up, and the patient feels chest discomfort. It is predictable. It comes with exertion, and it leaves with rest or nitroglycerin. No muscle dies, and troponin stays normal. Stable angina is chronic coronary disease. It is not acute coronary syndrome. What converts chronic disease into an emergency is a single event. A plaque ruptures. The body treats the ruptured surface as an injury and does what it always does with injuries. It forms a clot. Now the artery narrows suddenly instead of slowly. That moment is the beginning of acute coronary syndrome. And acute coronary syndrome has exactly 3 members. If the clot partly blocks the artery and the muscle is starved but not yet dying, we call it unstable angina. The tell is a change in pattern. The pain is new, or it comes at rest, or it is lasting longer, or it no longer responds to what used to relieve it. Troponin stays normal because nothing has died yet. Do not be reassured by that. Unstable angina sits one step from infarction. If the blockage lasts long enough that muscle begins to die, we call it a non-ST elevation myocardial infarction, an NSTEMI. Troponin now rises because dying cells leak it. The ECG typically shows ST depression or T wave inversion. And if the artery occludes completely, the ECG shows ST elevation, and we call it a STEMI. That is the one that sends people running, because a completely blocked artery is losing muscle every minute. The cleanest way to hold the 3 apart is by how blocked the artery is. Unstable angina and NSTEMI are partial or intermittent occlusion, and what separates them is whether troponin has risen. STEMI is complete occlusion. So how do we tell them apart at the bedside? 2 tools, and neither works alone. First, the 12-lead ECG. It is fast, it is available at the bedside, and it is the only thing that identifies a STEMI. That is why the standard is a 12-lead within 10 minutes of a patient reporting chest pain. Not eventually, within 10 minutes. One caution worth carrying. ST depression usually means NSTEMI. But ST depression in the leads that look at the front of the heart can be the mirror image of a true posterior STEMI. When the picture does not fit, ask for posterior leads. Second, troponin, a protein released when cardiac muscle cells die. Most hospitals now use a high sensitivity assay, which can detect injury within an hour or 2 and lets the team compare a second value against the first. That change over time, the delta, often matters more than any single number. 2 cautions. A single early troponin never clears a patient with ongoing chest pain, and troponin is specific to cardiac muscle but not to a heart attack. It also rises in kidney failure, sepsis, pulmonary embolism, myocarditis, decompensated heart failure, and fast rhythms. An elevated troponin tells you heart muscle was injured. It does not by itself tell you a plaque ruptured. Now the part that makes this nursing rather than trivia. Recognition is the intervention. The classic presentation is crushing substernal pressure, maybe radiating to the jaw or the left arm, with sweating, nausea, and a sense of doom. But many patients never look like that. Women, older adults, and people with diabetes present atypically far more often, with shortness of breath, unexplained fatigue, indigestion, or simply not feeling right. Diabetic neuropathy can blunt the pain completely, producing a silent infarction. If you only look for the movie version of a heart attack, you will miss the patients who most need you. When you suspect acute coronary syndrome, several things happen at once. And you usually start them. 12 lead within 10 minutes, continuous cardiac monitoring, because the most dangerous early complication is a lethal dysrhythmia. IV access. Aspirin, chewed, rather than swallowed, so it works faster, because it blocks platelet aggregation and measurably saves lives. Nitroglycerin for ischemic pain, but check first, because nitrates are dangerous in a patient who has taken an erectile dysfunction drug, and they can drop the pressure dangerously in a right ventricular infarction. Nitroglycerin relieves pain. It does not save the muscle. A word about oxygen and morphine, because many of you learned the mnemonic MONA. Let that mnemonic go. Oxygen is given only if the patient is hypoxic, because routine oxygen in a patient with normal saturation may cause harm. Morphine is now reserved for pain that nitrates do not relieve, partly because it slows absorption of the antiplatelet drugs that actually matter. The drugs that change outcomes are the ones that open and keep open the artery. Then comes the clock. For a STEMI, the definitive treatment is reopening the artery, and there are 3 numbers to know. At a hospital that can do catheterization, the target from first medical contact to opening the vessel is 90 minutes. If the patient must be transferred, the target is 120 minutes. And if neither is achievable, clot-dissolving therapy should be started within 30 minutes of arrival, assuming the patient has no bleeding contraindication. Every minute of delay is muscle loss permanently. That is what time is muscle means. It is a measurement, not a slogan. So carry this into our next class. The heart feeds itself in diastole. Ischemia is supply versus demand. Stable angina is chronic disease. Plaque rupture is what makes it acute. Acute coronary syndrome has 3 members, sorted by how completely the artery is blocked and whether troponin has risen. The ECG finds the STMI. Troponin confirms injury without naming its cause, and neither rules out disease alone. And the nurse who recognizes an atypical presentation early is the reason a patient keeps their heart muscle. When we meet, we will read 12 leads together, work through the full medication bundle with its hold parameters, and practice presentations that do not announce themselves. See you in class.